that is vulval psoriasis. Okay, so this is also one of the frequently asked SBA or EMQ. So what is the etiology? It's a chronic inflammatory epidermal disease. See, it's an epidermal disease affecting 2% of the population. Genital involvement may be part of in form of plaque or flagellal psoriasis can be there. Rarely there can be isolated genital involvement. Clinical features will include vulval itch, soreness, burning sensation, etc. Here, typical features of vulval psoriasis are they are well demarcated, bright erythematous plaques. Okay, what we have seen in lichen sclerosis, they were thin and white in color, while here you get a well demarcated, bright erythematous plaques. They are often symmetrical, frequently affecting the knuckle cleft, and usually lack scaling due to maceration fissuring. Okay, so these are the typical words you should remember. It's a well demarcated, bright erythematous plaques, symmetrical and affecting the knuckle clefts. Okay, so symmetrical and affecting the knuckle cleft. If you get this kind of description of the lesion, then select mostly as a vulval psoriasis is an answer. Okay, and there is a worsening due to the Kopner effect. So Kopner effect is the normal skin gets affected because of some trauma. It may be in because of urine or tight clothes or sexual activity. So wherever there is a trauma to the normal skin, so adjacent to that area, the skin will get affected. So there will be some lesion of after that there will be normal area, but due to the trauma, the normal area will show the lesion in another 2 to 3 weeks. That is the Kopner effect. So these are the typical words you should remember about the vulval psoriasis. Okay. Now, diagnosis, you have to examine the patient skin and nails for other psoriasis signs. Skin punch biopsy is required. Then treatment is a standard regimen. Avoid triggers, irritants, emollient soap substitutes to be given. Then topical corticosteroids. What you require is a weak or moderate steroids. Potent is required only for short term in psoriasis. Treat secondary infection with combined antifungal antibiotic. Coal tar preparation or vitamin T analogs can be used but may irritate. Okay, onward referral to the multidisciplinary vulval clinic for recalcitrant or unresponsive cases, or this is or if the systemic therapy is required. So mainly the initial treatment is with the weak steroids here, psoriasis. Okay, systemic therapy only for severe extensive psoriasis, not for isolated genital lesions. Follow up mild disease as clinically required, and severe disease 1 month then as required. Auditable outcomes are provide written information to all patients. Target is 100%. So that finishes the vulval psoriasis.